Hi, good evening.
How are you doing, Professor Maliawan?
Fine, thank you. And you just fine?
Yeah. I'm well. Yeah. Hopefully we are all healthy. Yeah.
Yeah, I already finished the
With the
third
third shot. Yeah.
session. Yeah, that's what one uh, AstraZeneca, the second AstraZeneca, and the last one Moderna.
Yeah.
Without just what a little bit pain, little bit discomfort at the site of injection.
Yeah. And is it finished for all the health worker in Bali or just with
Already.
already finished? Yeah.
Oh,
With the district hospital like in Gianyar, Bangli, Karangasem.
yeah, already.
Oh, okay.
Start. Maybe
Okay.
in Sanglah right now, almost all.
Yeah. Also the students and the
The student
residents.
also? No, not the student. Not yet the student.
Uh,
That's for
only
the
the
nurse.
resident, yeah, the
Yeah,
resident.
resident, nurse,
Hmm.
and staff.
Yeah, I hope because mostly the people with already shot with the two vaccines, two shots, still many victims. Yeah, even with health protocol and twice vaccination, but the mortality rate is still high.
Do you believe that Delta variant? Uh,
Yeah, that is proven, yeah, the Delta variant of the virus. But I think maybe another reason, yeah, why even people are already vaccinated twice or even the third times, but and also practicing the health protocol, but still the mortality rate quite high, and also the incidence rate. I don't know why. What is the reason?
maybe they come late. They just underestimate
Understood. Yeah.
what's the infectiosity of that. But for me, at home and all of the family members very tightly use the
Yeah.
protocol, uh,
Yeah. We have to
health
be
protocol.
very, very careful because the virus is very uh, communicable. Yeah. Especially the Delta variant. Good evening, Professor Andi Asadul Islam. Good evening, Professor Hendy Hendarto.
Malam Master Peter, Mas Peter.
Oh yeah, selamat malam, Prof. How are you
Siap.
doing, Prof? Yeah,
Just fine, thank you.
yeah. Thank
Saya
you.
ikut ya,
Yeah,
saya ikut. Ya,
thank you for joining.
ya,
Yeah,
saya mau.
Professor Abdul Syukur is my teacher, a very good teacher.
Oh no. Okay.
Thank you, Professor
Ya,
Syukur, for
kami
joining.
seminggu. Okay.
Selamat malam, Prof. Syukur.
Malam Mas Riwanto. Aku mau dengerin pidatonya panjenengan itu.
Prof dari Bali, Prof.
Maliawan, Prof. Itu siap, Mas Maliawan.
Dr. Kidal, we will start exactly at 7 o'clock.
Yes,
Yeah,
we
okay.
will get started 7 minutes left. Yeah, 7 minutes.
Okay, I still get a cup of tea.
Oh, okay. Take your time. Good evening, Dr. Ernawati. Good evening, Dr. Ernawati. Good evening, Dr. Ernawati. Good evening, Professor Hendy Hendarto.
Good evening.
And
Dr.
how are you
Peter.
doing? How are you doing, Prof.
Fine.
Hendy? Yeah.
Fine.
Still busy with your surgery?
Just relax.
Just relax.
Yeah, be careful, be careful, be careful.
Good evening, Dr. Ernawati.
Maybe it's still unmute.
Oh, yeah. Good evening, Dr. Frans. Good evening, Professor Georgios Tsoulfas. Good evening, Professor Paul Tahalele.
Good evening, Professor Riwanto.
Evening, Dr. Arifin. How are you?
Hello.
Frans.
Thank you for joining us tonight.
Good evening, Dr. Frans.
Good evening, Dr. Peter. I see Professor Abdushukur is here. I think.
Yeah. I'm ready for you.
Prof. Thank
I'm
you,
ready
Prof,
for you.
for attending
Yeah.
our meeting.
Indonesian 8.
Professor Hendy, thank you for attending.
Thank you, Dr. Frans.
Yes. Hello, Max. How are you?
Fine, Dr. Arifin. How are you?
Yes, I'm fine.
Good.
But how is the States? I think it's getting red now. There is a lot of transmission for COVID-19.
Yes, I was just speaking a couple of minutes ago with Dr. Manopo. The key concern at this time is the increased infections from the Delta
Yes.
variant. And now we hear a little bit about the Lambda variant. So there has not been a, I'm sorry. There's not been a lockdown, but there is increasing concern. And Dr. Manopo was asking about booster shots, and at the current time, booster shots are being recommended for immunosuppressed patients, immunosuppressed people, and maybe booster shots will be recommended in the short time future, but based upon a conversation I had with my internist family physician yesterday at Northwestern, that decision has not been made. So it's being considered, but it's not been decided whether to do that or not.
Okay.
But I understand, Dr. Arifin, as I was saying to Dr. Manopo, that the the COVID-19 situation in Indonesia is quite severe.
Yes, it is true. Yeah, we have actually the absolute number of cases is not as high as in the States, but
Yes.
the increase, the ratio of increase is very high. So it's
Yes.
second peak for our epidemic here.
Right. I'm sorry to hear that.
And the other problem here is the number of mortality rate. So there
Yes.
are a lot of people who's getting infected, and
Kok gini dia?
the mortality rate is over the average, the world average
Yes.
actually, almost 3
Yes.
times.
As I understand, based upon the communication from Professor Kwan, our world president-elect, as you know, there are a number of lives that have been lost to lives of frontline workers who are dealing with COVID, and that's very sad to hear. It's above average, as I understand, as you say.
We will get started in 1 minute.
Okay.
For those who are not speaking in this session, would you please mute your microphone so that will not disturbing for this session. Good evening, Professor Andi. Good morning, good afternoon, and good evening, everyone. Welcome to the 18th chapter of the webinar from the ICS Indonesia section. Today with the theme of challenges in surgery. My name is Dr. Peter Johannes Manopo. I will be your moderator of this session. And first of all, on behalf of the ICS Indonesia section, I would like to express my gratitude for all the participants for your
Dah selesai. Dah. Dek, kenapa gini, Dek?
Excuse me. Would you please turn off or mute your microphone for those who are not speaking? Thank you. So, particularly, I would like to express my gratitude to our speakers today. First, Professor Riwanto, a GI surgeon, the member of the ICS Indonesia section, and Dr. Ernawati, the Ob-gyn surgeon from the Ob-gyn department, Dr. Sutomo Hospital, Surabaya. I would like first to invite Professor Sri Maliawan, who will address the opening speech on behalf of the Indonesian section, because he is the president-elect of the Indonesian section. Professor Sri Maliawan, the floor is yours.
Good evening, good afternoon, and good night to everybody, ladies and gentlemen. It's my pleasure to announce that we tonight have, on behalf of FICS Indonesian section, I am very glad that tonight we have ICS Surgical Forum, Chapter 18. And then we have two distinguished speakers. It was Professor Riwanto from Semarang, and the other one is Dr. Ernawati, OB-GY from Surabaya. Thank you. It must be very interesting because the title was well, at least knowledge about GI tract, and the other one is sexual cesarean. Good night again, and enjoy the surgical forum, 18 surgical forum of ICS Indonesian section. Thank you, Mr. Moderator. The podium now, it's yours.
Thank you, Professor Sri Maliawan, for your opening speech. And now I would like to invite Professor Georgios Tsoulfas, the World President of the ICS. Professor Georgios Tsoulfas, are you on the line? Maybe later he will join us. For the next, I would like to invite Professor Hendy Hendarto, the Vice President of the ICS Indonesia section, to address the scientific notes. Professor Hendy Hendarto, the floor is yours.
Thank you, Dr. Peter. Good evening, good morning, and good afternoon, everybody. Welcome and thank you for joining International Virtual Surgical Forum, Chapter 80, Indonesian section. From the scientific note, I inform you about the news from the ICS US section, the short article from David B. Mendel. He is an attorney and author for more than a dozen books of the doctor. The title of the article is the Protecting Against Malpractice Liability. This article states that there are three-part solution to the challenge of shielding wealth from the potential malpractice claim. The first, risk management. The first strategy is to reduce risk and practice the best medicine possible. This begins with dedication to being the best physician you can be and maintaining your ongoing knowledge through the education and continuing medical education. And the second, medical malpractice insurance. Perhaps the most obvious way to protect against malpractice claim is to purchase medical malpractice insurance. And the last, asset protection. Mistakes will happen and bad outcome will occur even when all best practice were followed. So personal asset protection are needed for shielding the physician home, retirement account, and other investment account. That's all I think about the scientific notes today. I hope we all stay healthy and stay safe. And finally, thank you for all speakers for sharing your experience. Thank you very much for your attention. Thank you.
Thank you very much, Professor Hendy Hendarto, for your scientific notes. And now I would like to invite Mr. Max Downham, the World Executive Officer of the International College of Surgeons. Mr. Max Downham, the floor is yours.
Thank you, Dr. Manopo, and I thank Professor Maliawan, Professor Hendarto, Professor Islam, Dr. Arifin, certainly welcome to Professor Riwanto and Dr. Ernawati. On behalf of ICS-World President, Professor Georgios Tsoulfas, who's based in Thessaloniki, Greece, we commend the Indonesian section. I can't say this too often, Dr. Manopo. We commend you again, all of you and your colleagues, for conducting these webinars, which I think is just absolutely wonderful. So commendation, kudos to you, as we say in the US and perhaps elsewhere in the world. And on behalf of Professor Tsoulfas and the leaders, we are very appreciative to be part of this. I have three quick points, Dr. Manopo, as an update. One is that there is another section that is emulating or conducting a webinar on August 28 and that is the Taiwan section of the International College of Surgeons. They'll conduct it on a Saturday, 1520 hours to 1700 hours Taiwan time, which is GMT +8, the topic being cholangiocarcinoma. A distinguished Japanese surgeon, Professor Yuji Nimura, will be speaking on the topic of cholangiocarcinoma. So we're very pleased that Taiwan has joined Indonesia in this type of effort. Professor Kun Kai Kuo is the president of the section, is a person that you can contact if you have questions. Second is that I'm very delighted on behalf of the International College of Surgeons to tell you that the Washington Post, which is a major newspaper in the United States, and I believe other parts of the world, has ranked and included the International Museum of Surgical Science, which is a division of the International College of Surgeons parent body, as one of the 8 best medical museums in the United States. So we're very pleased about that. That happened just 2 days ago. And so I'm happy to share that information. The third point is that elections are about to occur for the year, the administrative year 2022-2023 in the International College of Surgeons. And in reference to those elections, as I think most of you are aware, but I will say it, the International College of Surgeons is technically a legal federation around the world, with such as Indonesia being a separately incorporated legal entity that is then in a relationship with the parent body. So we've put out a call for nominations, including the Indonesian section. If you want to submit nominations, please do so. And we'll be proceeding into the elections, which will occur by direct mail vote after November 16 this year, 2021. And it is an opportunity, should the section so decide, to submit nominations. And we would appreciate receiving those nominations this month. Actually, should be a curriculum vitae for professional, and then a curriculum vitae for college activities. So with those 3 notes, and hopefully I didn't take more than 2 minutes, Dr. Manopo, but at any rate, thank you so much again for allowing me to participate in this wonderful session, and many commendations to you and the Indonesian leaders. Thank you, sir.
Thank you very much, Mr. Max Downham, for your ICS updates note. And for the next, I would like to invite Dr. Frans Arifin, the Secretary of the Indonesia section, to address the section notes. Dr. Frans Arifin, the floor is yours.
Thank you, Dr. Peter. Can I share a screen?
Sure, you can do it.
Okay, just a minute. So I would like to update the latest activity of the ICS Indonesian section. In the last 2 weeks, we are working with the International College of Surgeons Global and the ICS Taiwan to provide some of the medicine and medical equipment to support the physician in Surabaya and East Java. So in the last week, we hand over several of these assistants to hospitals and to the Surabaya city government. Just a moment, it's a little bit difficult. Bear with me. I will show the 2 minutes video about on our handover. Is it shown in the monitor?
Yep. Perfect.
Can you see, Dr. Peter? Okay.
Okay.
Could you put it in full screen?
It's already in full screen here.
Oh, okay. Okay.
Is it? I don't know how is it displayed. Is it okay?
Yeah. Perfect. Maybe from the host, yeah.
Sorry. That is all, Dr. Peter. Thank you very much. That's the update of the Indonesian section for this month.
Thank you very
The
much.
time is yours.
Yeah. Thank you very much, Dr. Frans Arifin, for addressing the notes of the section and the videos. And then I think we come to the end of the opening session, and for the next we will enter the scientific session. And for the first session of the scientific part will be presented by Professor Riwanto with the topic on challenges in GI surgery. Professor Riwanto, the floor is yours.
Thank you very much, Dr. Peter. I want to know whether my sound is clear.
Yeah, it's clear.
It's clear.
Perfect. Yes.
Yeah. Let me share my screen.
Sure.
Hey, good evening, good morning, or good afternoon for all of the audience. Dear Mr. Max Downham, Executive Director of ICS Global, Professor Sri Maliawan, President-elect of ICS Indonesian Section, Prof. Hendy Hendarto, Vice President of ICS Indonesian Section, Prof. Andi, Asadul Islam, Research Vice President ICS Section, Dr. Frans Arifin, Secretary ICS Indonesian Section, Professor Abdul Syukur, my friend, and Dr. Peter, Fellowship and Ethics Committee ICS President Section, and the moderator of this webinar, and all of the participants on this webinar. My name is Ignatius Riwanto. I'm from Department of Surgery, Diponegoro Medical Faculty, Semarang, Indonesia. First of all, I would like to thank to ICS Indonesian Section for inviting me to talk in this prestigious webinar with the topic, the challenges of surgery. And the committee asked me to talk about the challenges of gastrointestinal surgery. But as I know that the challenge could be specific for certain places, country, or centers. So I make the topic more specific. The challenges of gastrointestinal surgery in Indonesia. According to the Cambridge Dictionary, challenge is situation of being faced with and should find solution to this problem. Therefore, I would like to talk about the recent development of GI tract surgery in the world. And then we want to know about the position of GI tract surgery in Indonesia nowadays. We will detect the gap between the development of GI tract in the world and the development of GI tract in the Indonesia, and try to find factors that influence the gap, and of course, the suggestion for solution. As we know that the development of gastrointestinal surgery technique is so fast recently. A lot of open surgery are done through minimally invasive laparoscopic surgery. Some experts are not satisfied with even minimal abdominal scar. Therefore, develop natural orifice surgery using scope through natural orifice like mouth, anus, or vagina to remove the abdominal organ. Initially, or some with still with hybrid laparoscopy, but I think only a matter of time could be purely natural orifice surgery. A lot of handicaps are faced during laparoscopy surgery or natural orifice surgery, especially regarding the view and instrumentation. Therefore, experts develop robotic surgery, and next will be robotic nodes. The other development GI tract surgery in the world is regarding the organ transplantation, and especially liver transplantation that already developed so fast in the developed countries. About the minimally invasive surgery, nowadays, many difficult GI tract surgery now become possible through laparoscopy surgery. A lot of Indonesian digestive surgery already done. T3 gastric resection or low anterior resection. But only few start to do esophageal resection, liver resection, and nipple operation through laparoscopic surgery. If we try to find in the literature, meta-analysis show that laparoscopic and robotic liver resection superior to open surgery regarding blood loss, morbidity, length of the stay, and although not significant, the mortality is also lower in the laparoscopic and robotic liver resection. We in Semarang already start to do liver surgery through laparoscopy. We have 11 cases. Since 2018, one of our staff, Dr. Eric, started to do laparoscopic liver resection. Among 11 cases, 5 primary hepatocellular carcinoma and 5 metastatic liver carcinoma and 1 cholangiocarcinoma. And mostly did anatomical resection, and 3 cases combination with the open laparotomy called hybrid method. Regarding laparoscopy pancreaticoduodenectomy or Whipple operation, systematic review in year 2011. Only 2024 patients were included. Reported that no significant difference regarding 90 days mortality, length of stay, bileak, reoperation, readmission, oncologic outcome, postoperative pancreatic failure, etc. between laparoscopic and open people operation. But blood loss was lower in laparoscopic group. Since it is still small sample and high risk bias, I think not can be concluded until now. Further study is still needed. And we are in Semarang already done laparoscopic people operation, but still hybrid. Means that dissection and resection done laparoscopically, but the reconstruction using open wound. Yeah. We already done in 16 cases. I think it is very important to start because if you see the next meta-analysis show that gives a promising result for robotic and laparoscopic people operation. Now, expert also developed the natural authorized transluminal endoscopy surgery, or NOTUS. Endoscopy initially used for diagnosis, later on for surgical treatment, like polypectomy or endoscopic mucosal resection with suturing the defect. Successful in suturing endoscopy drive the expert to open the gastric wall and to do transgastric perineoscopy, and later transgastric appendicectomy and cholecystectomy. Now, many surgeons prefer transfunctional, removing the gastrointestinal organ, like cholecystectomy, gastrectomy, or sigmoidectomy. And meta-analysis also already showed that hybrid nodes reduce the postoperative pain, complication, greater cosmetic satisfaction in comparison with laparoscopic surgery. In Indonesia, it is the pioneer for hybrid notice is Dr. Reno Rutuman. This is the first report in international surgery, July 2009. One cases with transvaginal cholecystectomy, but it is still hybrid. I mean that I think that it is still need a hole in the abdomen. And thank you for Dr. Reno Rutuman for permission this slide regarding the notes. Up till now, 4 cases cholecystectomy, 2 transvaginal and 2 transgastric. How about notes for rectal surgery? I think now also developed so fast for rectal surgery. Transanal excision without scope in combination with open or laparoscopic dissection of the rectum can be done easily for low or rectal anterior resection like this. We can dissect the rectum through laparoscopy or laparotomy, and then we can cut the anus, the rectum from below without scope. Yeah? We did already this method for several cases. But nowadays, the development of rectal scope completed with the special instrument started with transanal endoscopic microsurgery produced by Richard Wall. and transanal endoscopic operation processed by Karl Storz. And then one tried to using single incision laparoscopic surgery port, and then develop gel point pad. By using cells or gel point pad, we can use laparoscopic tower and also laparoscopic instrument. And result of the meta-analysis show that transanal TMA is superior to laparoscopic TMA regarding RO resection, number of harvested lymph node, lower rate of circumferential margin positive, and conversion to open procedure. I think this transanal TMA show that superiority with the result. We can use laparoscopic tower and use laparoscopic instrument using cell port or gel point pad. I think in Indonesia should start to do TRTMA. How about the robotic surgery for GI tract? I think the development of robotic surgery is to solve many of the mechanical and optical disadvantages of the laparoscopy. Robotic surgery instrument allow flexible wrist movement capabilities, self-assistant through third robotic arm, high definition three-dimensional view, and stabilized surgeon control camera. And the superior ergonomic and surgical dexterity provided by robot result from the instrument with 7% of freedom, 7 degrees of freedom, 90 degree of articulation, and 540 degree rotation. Therefore, it is permitting manipulation within a small spaces or narrow spaces like in the pelvis. Here, so that robotic pancreatic duodenectomy superior than open pancreatic duodenectomy regarding resection margin, number of lymph node, harvesting, and blood loss. In Indonesia, only one robotic equipment that is in Bunda Hospital. According from some information, mostly for gynecological surgery. Some urologic surgery, only a small number with GI tract surgery. It is information from Dr. Reno that did the robotic surgery in Bunda Hospital. Now operated more than 300 cases, mostly gynecological surgery and some urologic. But for the GI tract surgeries were adhesiolysis and Roux-en-Y bypass. How about robotic notice? Now still under development, since it should use different instrument compared with regular robotic surgery. The instrument of our robotic notes can be flexible scope with some hole for articulating instrument, camera, and lighting. So like this, the Cobra triangulating scope is used for notice through gastric, but also can be rigid scope that from the rigid scope can be passed several articulating instrument, camera, and lighting. It can usually used for transvaginal natural orifice. So can be combined with robotic. It is not much case report, but this one already been reported about the robotic nodes. 13 cases reported transvaginal nodes for hysterectomy. I think now still possible, but still under development. So about the organ transplantation, we know that in GI tract surgery, now also developed the organ transplantation, liver transplantation, pancreas, and intestinal transplantation. But the most developed now is liver transplantation. Liver transplantation is an effort to change the liver failure with liver donor so the patient can live longer. Therefore, the measurement of success are patient survival and graft survival. Yeah. According to this meta-analysis, show that transplantation in infant, so patient survival 1 year, 85%, 1 year, 71%, and 5 years, 80%. It can be concluded that the liver transplantation is very useful for patients with liver failure to prolong the life. And in Indonesia, only few centers develop liver transplantation. This is the Cipto Mangunkusumo Hospital, Faculty of Medicine, Sarjito Hospital in Yogyakarta, and we already have experience in Undip. But I heard that also Adamali Hospital in Medan. Yeah. Here, report from Dr. Toarlalisan, death of the digestive surgery in Cipto Mangunkusumo in 2016 about the liver transplantation. He report in the Hepatopancreatobiliary International Meeting, already done 9 living donor, 6 pediatric and 3 adult cases. Yeah. And the other is the next in 2020, pediatric living donor, already done 45 pediatric liver transplantation in Cipto Mangunkusumo Hospital. So, about the present position of GI tract surgery in Indonesia, you can summarize like this: laparoscopic liver resection and lipo is only few centers, not just few cases. Transanal total mesorectal excision is no information or report. Robotic surgery is only in Jakarta, very few number of cases. Robotic nodes, no information or report. Liver transplantation, only in Jakarta, already established. So what is the problem? I think it is a big problem in Indonesia regarding the advanced surgical technique. Why? Because it is not national program. It is not national program. Therefore, providing sophisticated instrument by the department or by the university or by the hospital is impossible because very, very expensive instrument. And also, therefore, we have lack of facility. And also, national health coverage do not support the development of advanced GI tract surgery. For example, National Health Insurance do not cover laparoscopic surgery. Laparoscopic cholecystectomy, laparoscopic appendectomy is not covered by National Health Insurance. From above reason, GI tract surgeon in Indonesia reluctant to improve surgical technique that using sophisticated instrument. Why? Because they say, what for? I can use the specific instrument, but I can do nothing because there is no instrument in my hospital. Therefore, now in Indonesia is the limited expert in specific surgery, including specific sophisticated instrument handling. The other recent problem is less number of patients eligible for major curative surgery. Yeah, because like we doing the TATMA, transanal total mesorectal section, should be rectal cancer that can be done achieving R0. I mean that clean. But most of the patients usually come in the late stage. And the other problem is regarding the transplantation. The problem is the existence of donor, yeah, both cadaver and living donor. So how to solve that problem? It is my own opinion, but I do hope any other suggestion to solve that problem, maybe from Professor Tsoulfas or Dr. Arifin. I think we have already heart hospital. We have already brain hospital, but we don't have a GI tract hospital. Yeah, I think government should develop specific GI tract hospital. Yeah. Not only heart or brain hospital, and should be equipped with the sophisticated instrument like advanced laparoscopic set, robotic surgery, notice, and so on. And train the team, including doctor, nurse, laboratory, clinician, and so on, in advanced center in the developed country. And later on, the hospital should be working under the supervision of the expertise from abroad. Also, national health coverage should be reformed so that national health coverage is hoping that also support the development of advanced GI tract surgery. To provide the expertise in specific GI tract surgery, I think subspecialist GI surgery in Indonesia should be more specific. Now, digestive surgeon is general GI tract surgery. The next should be more specific, like hepatopancreatobiliary, upper GI, or colorectal. To get the patient eligible for curative major surgery, the only way is the national detection program should be activated. And for getting the organ donor, it should be a national program also, and networking to get cadaver or living donor should be done by the government. And just today, I got good news. Two hospitals in Indonesia, Hasan Sadikin Hospital Bandung and Sarjito Hospital Yogyakarta, will be equipped with Sina robotic surgery from Iran. I don't know about the cooperation between Indonesia and Iran, but actually this is information that two hospitals in Indonesia will get the robot. I think this is all I can inform to you. I hope that it is useful and fruitful to you all. Thank you very much, Dr. Peter.
Thank you very much, Professor Riwanto, for your very informative presentation. We will get the discussion after the second presentation. So for the next, I would like to invite Dr. Ernawati, an Ob-gyn surgeon, to deliver the presentation on challenges on cesarean section. Dr. Ernawati, the floor is yours.
Yes, thank you, Dr. Peter. Good evening, good afternoon, good morning, everyone. And firstly, thank you for ICS Indonesia section for having me in this very nice discussion, I think. I will talk about C-section challenges in pandemic era. Let me share my screen.
Oh, sorry, I stopped
Yeah, sure.
first. Okay, thank you.
Let me introduce myself. I am Ernawati. I am staff in Ob-gyn Department Medical Faculty Universitas Airlangga, Surabaya. Today we will talk about cesarean section challenge in COVID-19 pandemic era. I think in previous Prof. Riwanto talking about the improving GI surgery, but I will talk about the current situation in Ob-gyn during pandemic area. As we know that cesarean delivery is one of the most common major surgical procedure performed in operating room, and right now the rate is generally rising. And cesarean delivery is one of the type of surgery that can't be postponed. I think during this pandemic, most of surgeons stop the operation, but obstetrician can't. Sorry. The indication of C-section, three most common indication is usually failure to progress during labor, on non-reassuring fetal status, or fetal malpresentation. But there are many other indications. And today, the maternal infection is rising sharply due to COVID-19 pandemic. So C-section cases ringing the alarm that why it's increased so sharply in during this pandemic, because the rate in one study said until 93%. But even though C-section, there are no sufficient evidence to support that C-section is better than vaginal delivery during this pandemic to prevent possible vertical transmission from pregnant mother to the fetus. But from this journal in JAMA Pediatric, that we also involved in this journal, among 2,000 samples, it said that women with COVID-19 diagnosis had a lower rate of spontaneous initiation of labor, but have higher cesarean delivery rate. So this situation makes us fear what happened in obstetrician field, why we choose C-section. We think that delivery had beneficial for the subsequent treatment and outcome of COVID-19 patient, and we think that excessive ventilation and stress during labor might aggravate the respiratory and pro-inflammatory status, or social problem. Maybe obstetricians are reluctant to expose with patient whose PCR status is unknown, or we think that we can reduce inpatient maternal stays or cross-infection and the use of protective equipment longer if we do vaginal delivery. And sometimes we also think that there are difficulties in transportation or referral transfer due to the lockdown situation. It make this reason make C-section is increased highly. This is data from 4 academic hospitals in Jakarta, Bandung, Surabaya, and also in Solo. It shows that C-section cases is increasing, and mostly in Jakarta, 89.18% patient with COVID-19 infection are performed C-section. Surabaya have the highest cases of pregnant women with COVID-19 infection, and our rate is 53, and average in Indonesia, this is the sexual cesarean rate during this pandemic is 57.57%. This number is increasing during this pandemic time. And we know that the increasing cases that we have to realize that C-section also increase risk of the viral spread in the operating room, also risk exposure of medical staff and uninfected fetuses due to the virus. And usually C-section is often performed urgently since the life of the mother and the fetus could be at risk. So in this situation, we need to know the infection status of the patient, because if we know the status of infection, we can provide the appropriate health services provider. This is becoming our concern because many research show, or we know that we every day hear sad news that we lost our college, we lost our family, or we lost our friends due to COVID-19 infection. And from literature said this because of we assume that direct contact with COVID-19 patient increasing the likelihood seropositivity among employee, and then unprotected and prolonged patient contact will also increasing the exposure, and the use of appropriate PPE can reduce the spread of SARS-CoV-2 infection. So we have to know the status of infection is very important in this situation. But we don't know the exact risk of acquiring COVID-19 in the healthcare setting, because it might be any different in the type and duration of exposure, and also the stage of infection itself. This is the data from Indonesian Society of Obstetric and Gynecology Mitigation team. This is, I think, still raw data because maybe it's a larger number than this one. From this, we got 18% among OB-GY in Indonesia survivor of COVID-19, and 43% are resident, and 56% are obstetric and gynecologists. And from this, we know that 82% of the doctor will contact with patient with COVID-19 infection, and the most of surgery that they have done was C-section. So we have to be careful, even though C-section is simple surgery, but it also can aggravate infection. Data from our hospital last year, we got 66% with asymptomatic condition, and if we got asymptomatic patient condition, sometimes make us don't realize that this patient have infection, so we usually don't wear appropriate PPE. So because of the number of asymptomatic patients is higher, we have to make a preparation for C-section during surgery on COVID patient. So in this section, we will discuss about pre-operative screening and testing, creating isolation operating room, pre-operative patient transport, also complication during surgery. Pre-operative screening and testing is I think, the most important in pre-operative preparation, because of we will use appropriate PPE, or we will preserve the appropriate operating room if we know the status of the patient. So in our department, we have guideline that we have to test for all patients who come in our hospital. And we use rapid PCR or rapid antigen test, depend on the facility. Sometimes we have to change the guideline because of the facility available in that time. And then we use that validity period for SARS-CoV-2 PCR is 24 until 72 hours. And for non-emergency surgery, the patient should be tested for COVID-19 last 3 days prior to surgery. This situation make operation need longer time, because we wait for the result of the PCR. It's need 24 until 72 hours. So sometimes in this situation make us in a very difficult situation. This is the screening that we use. Ideal, we have to use rapid RT-PCR or gene expert, but sometimes there is problem on availability. So we in the earlier of the pandemic, we use rapid antibody. But we stopped it in March, and then we changed to rapid antigen and ID no. But we also realized that these tools is also have lower sensitivity, only 60% if we compare with RT-PCR. But we have no choice. We in emergency situation, we use this rapid test, because if we with PCR, we need a longer time to test. This is from Dr. Manggala study that if we only use chest X-ray and rapid antibody, we have less sensitivity tools than the actual. This is the screening and testing guideline. So if the patient came to our emergency room, and then we will ask about the status of the patient. If the patient already bring the result of the test, and then we will bring them, if positive, in red zone, if negative, in green zone. But if the patient didn't bring the result, we will do the rapid test. And then we will grouping them into red or green or yellow. If yellow is if we don't have the result of RT-PCR, but we have a rapid antigen or rapid PCR, we bring them in a yellow area. If we got the specific result, and then we send them to isolation ward. So after we prepare the patient before operation, we have to create isolation operating room. That we know that isolation room have to fulfill the requirement. Operating room must have a HEPA filter, also have negative pressure, or must have a higher extent of cycle rates, more than 25 cycles per hour. And then doors should be remain closed during the procedure. And then we have to prepare separate area like clean, semi-contaminated, and contaminated. And also we have specific isolation operating room equipment and supplies. Because of this requirement, some hospital cannot fulfill the requirements. So not all hospital in Indonesia, mostly in Surabaya, have isolation operating room. So they will transfer the patient to our hospital. So it makes increasing cases in our hospital, and the impact is delay in response time and also worsening maternal and neonatal outcome. And then the next is pre-operative patient transport. After we decided to do C-section to this patient have to transport to the operating room. The patient have to wear N95 mask, and personnel have to wear secondary PPE, and we have to having a special route to isolation operating room and design elevator and avoided crowded area. But it's very difficult during our second wave outbreak, that it's very crowded in our hospital, and then limited staff because of most often have to rest because they get infected. So it may delay in patient transport and also worsening maternal outcome. This is the picture, the situation of our hospital during last 2 weeks, that our emergency room fully loaded with patient, and then we can move along the ward. So it makes us very difficult to appropriate treatment to the patient. So how about intraoperative care during cesarean delivery? All healthcare workers have to wear PPE before patient enter the operating room. In this picture, in the left side, one nurse have to help the surgeon or the people who will do operation to make appropriate PPE. And then after all of the team wearing PPE, and then patient will transfer to the operating room from quarantine room. We have to set up the operating room and also the team before patient entering the operating room. And then during operation, fluid, drug, and other equipment required for surgery and anesthesia were prepared in sufficient quantities. And then the anesthetist will preferred is spinal anesthesia, but they also prepare for general anesthesia. And we minimize the number of care provider in operating room to prevent transmission. And then after surgery, the patient have to recover in operating room before we send them to the isolation ward or ICU isolation. And this is it. And this situation made some problem too, because of limited isolation ICU with ventilator machine or isolation ward. And then difficulties to transport patient from operating room. So it will impact on limit operating capacity. So we have to create the emergency case that we can do C-section in that time. So it must be have an impact on increase in maternal and neonatal morbidity and mortality. So the situation may delay in emergency C-section response time, that we have standard in emergency C-section response time. We have to fulfill that in 30 minutes. The patient have we decide that this the operation, the patient have to transfer to operating room, and then we have to do operation or incision. But in this current situation, we cannot do this. The average response time increased from 30 until 106.21 minutes on average, and this is in emergency room because of the previous situation that I have explained. And we analyze this problem is because of the patient going in the elevator or operating room is not ready yet when it will sign in, Or operator sometimes is not ready in the operating room when the patient is signed in. And then healthcare worker have not been trained with current COVID-19 protocol during surgery. And also it depends on the severity and degree of difficulty during anesthesia or surgery procedure. So it will delay the emergency C-section response time. There are also technical difficulties during surgery. And we know that the use of PPA is make us feel uncomfortable during surgery because of we will melt during in the operating room because of wearing fully PPA, and it makes our vision is blurred because of the goggles and face shield are fogged up, and then it make operation field it's less clear, and because of fear of prolonged exposure, sometimes the operator have to stop the operation immediately because of we afraid of increasing COVID-19 transmission. So during this situation, operation is usually very, very uncomfortable. So after deliver, and then the baby will bring to usually we will go to bring them to outside the room, and then we will warm the baby in the outside the room to prevent transmission. And then COVID-19 also increased the complication during surgery. From this case report that intraoperative coagulopathy during cesarean section will aggravate the bleeding during surgery. That widely accepted that SARS-CoV-2 induce a hypercoagulable state and produce an elevated rate of thrombosis. But some report says that dimer is a marker of both an activate coagulation and process as well as fibrinolysis, also made increasing of fibrinolysis and increasing of bleeding during operation. This case report is there is a basal ganglia hemorrhage and upper GI bleeds among patients with COVID-19. So in pregnant COVID patients also have higher risk for intrapartum or intraoperative bleeding due to COVID-19 risk itself or effect of anticoagulant therapy that we give for prevent hypercoagulable state. This is our case report from Universitas Airlangga Hospital. This is Mrs. L, 30 years old. She referred to our hospital due to placenta previa, total placenta previa, and heavy bleeding. And then we decided to do emergency C-section in that time. And during the operation, after delivering the baby, we found active bleeding from placental bed, and then we did cross-stitch suture. And then after that, uterine became hypotonia and no response with uterine massage and uterotonic agent. And then we did Billings procedure. And during the first surgery, there are 3.5 liters of bleeding. And 6 hours after C-section, we observed that there is still active bleeding, and then we decided to reopen this patient. And during the second surgery, we found there is atonia, and then we decided to do hysterectomy to control the bleeding. And the second surgery is the bleeding is 1.6 cc. And then 3 days after the second surgery, the patient showed sign of sepsis and obstructive ileus, and we found solid mass on lower abdomen. And then we did abdominal CT scan, and the result is there are enlargement of uterine and in irregular edge, suspected a gynecological mass and dilatation of bowel to large bowel because of compressing of this mass. But this patient already did hysterectomy, so we presume that this is about because of abdominal hematome. And this is the picture of the CT scan that we found mass in the uterine position, and we do that this is hematome. So we observe this patient because no decreasing of hemoglobin level at that time, and we plan conservative management to treat the sepsis first. But the patient getting worse and the patient passed away due to septic shock. In this case, we found that the dimer is 5.1, and this is higher than the standard dimer normal in pregnant women. And we analyzed that in this case, bleeding can occur from placental bed, maybe placental previa is one of bleeding risk, and then the second is uterine atony secondary to the massive bleeding, and hematome occurs related to coagulopathy in this patient. So we think that COVID-19 may increase infection and increase bleeding risk in this patient. So postpartum management, we did management of usual postpartum issues, I think PTH prevention, and also we follow up for any respiratory decompensation. And for patients with COVID-19 in isolation ward, we have video for observe and also phone call visit and consultation to prevent contact with the patient and prevent cross-infection, but this may increasing risk of delay in detecting complication to the patient. So as the summary, that fearing the increased rate of C-section and iatrogenic preterm delivery, even though there is no sufficient evidence supporting that cesarean section is better than vaginal delivery in preventing possible vertical transmission and improve maternal condition. And then there are the risks of prolonged peri-operative preparation, complications during surgery, and delayed treatment of postpartum complication increases. And also peri-operative management guidelines for suspected cases of COVID-19 are required to prevent transmission of the virus to vulnerable surgical patients and also healthcare workers. Thank you very much, and thank you for all of our residents for take care of our COVID-19 patient and also supporting a nice picture in this presentation. Thank you very much.
Thank you very much, Dr. Ernawati, for your very informative presentation. Now we come to the discussion session, but before I open the discussion to the floor, I would like to invite Professor Andi Asadul Islam for addressing the summary note. Professor Andi, the floor is yours. Professor Andi, the floor is yours. Please unmute your microphone. Okay, maybe later on he will address the summary note. Now I open the first part of the discussion. The first part will be the inter-speakers discussion. So I will give the first opportunity to Professor Riwanto. Professor Riwanto, do you have any question to Dr. Ernawati? Please unmute your microphone.
Yeah, sorry, I'm no question for Dr. Ernawati.
Yeah, please.
Yeah. I have no question. I have no question.
Oh, you have a question. So,
Yeah.
Dr. Ernawati, you will be the next. I will give the next opportunity to ask question to Professor Riwanto.
Okay, thank you, Dr. Peter. I have a question for Prof. Riwanto. I think in obstetric and gynecology field, we have we impacted to the COVID-19 pandemic. And how about in GI surgeon field? Do you feel there any impact or in surgery or in cases during this pandemic situation?
Professor Riwanto, it's your turn to react to the question of Dr. Ernawati.
Yes, I know that. Yeah. Actually, I myself have no experience about the case with COVID and have GI tract surgery. I personally have no experience, but from friend of mine that get some cases with tumor in the retroperitoneally, and according to the CT scan that it semi-solid tumor, and do the operation, but actually this is hematoma only. And the patient have a history of the COVID before. This is what I can. It means that that is true that some cases patient with COVID get the problem with coagulation. It means that coagulopathy, but also information from my colleagues from vascular surgeon that some COVID patient get the deep vein thrombosis. Yeah, but I have no experience for myself. I have no experience about patient with COVID and GI tract surgery.
Thank you very much, Professor Riwanto. Is there any question? Any other question, Dr. Ernawati or Professor Riwanto?
Enough, Dr. Peter. Thank you.
Okay, thank you. I have a question to Professor Riwanto first, and then later on will be to Dr. Ernawati. Professor Riwanto,
yeah.
Based on your own experience, is there any infection by the natural orifice surgery? Because we know that in the natural orifice, there is a normal flora of the bacteria. So if you make the approach through the normal orifice, is there any higher risk of infection, or is not a problem?
Sorry, Dr. Peter, I have no experience in doing notes. In Indonesia, only Dr. Reno did 4 cases notice through the vagina and through the gastric. According to Dr. Reno, there is no complication with infection. I think the good preparation and protect with good antibiotic is no problem with infection for notice.
Thank you very much, Professor Riwanto. To Dr. Ernawati, how often you did the test of COVID-19 to the patient or to the mother after the C-section? Is it should be repeated the test after the C-section, and how often is it done? And how about the baby? The baby should be tested also, or it's not necessary to test the baby? Thank you.
Thank you for the question, Dr. Peter. In our guideline, if we already test the patient, in the first guideline, we have two time tests for PCR this patient. If in emergency C-section, we do in first and when the patient coming, and then the next day we will test the patient too. But in recently, we only do one test, and we will repeat the test if we got, I think, might be in the first test a negative, but the patient showed sign or symptom of COVID, and then we will repeat the test. But if no, we only do before operation or when before operation we cannot get the samples. I think because in emergency situation after the operation, then we will take the PCR test. And for all the baby from the positive mother, we do PCR2 in the 24 hours of the birth, after birth, 24 hours after birth. And actually the risk of the case positive of the baby is low of the baby, not until 5%, I think, from the positive mother.
Thank you very much, Dr. Ernawati. And now I will open the discussion to the floor. Is there any question from the floor to the two speakers? You can ask directly.
Dr. Peter,
Yes,
I have a question to Professor Riwanto.
sure. Please.
Professor Riwanto, thank you for your presentation. I have a question about the robotic surgery and only in Jakarta. It is about a question about the training for the surgeon about the robotic surgery. Is it easier or more difficult to perform robotic surgery compared with laparoscopy or laparoscopy, compare laparoscopy?
Please, Professor Riwanto.
Okay, thank you very much, Prof. Hendy Hendarto. I have no experience myself with robotic surgery. I just inform you that in Indonesia, only Jakarta, and the digestive surgeon who involved in the robotic surgery in Jakarta is Dr. Reno Rudiman from Bandung. And according to him, that if someone already expert in laparoscopic surgery, it's not so difficult to study to train about the robotic surgery. But of course, it needs time for getting learning curve. I think according to Dr. Reno, it is possible. So if according to Dr. Reno also, because he one of the member of the team come to Iran to sign the memorandum of understanding, said that even the bariatric surgery SINA is places in the UNPAD and in UGM, but other expert can use that. I mean that can study there after the equipment already setting.
Yeah,
the next maybe from digestive surgery and maybe from Sp.OG should organize how to train the bariatric surgery. Yeah. I don't know when the equipment will come.
Okay.
The second question is, you know what, robotic surgery is very expensive.
That's right.
And about the patient, is there an advantages of the robotic surgery for the patient?
Yeah, of course, should be a difficult surgery using the robot. Not all of the surgery, of course, because very expensive. Therefore, I read from the paper that even one hysterectomy can be done through notice through vagina, because using articulating instrument and also articulating scope that can turn more than 90 degrees. Therefore, can be look back and can do something from below, from vagina. Yeah, I think it is promising for us if the instrument, I mean that the bariatric surgery from Iran already come to Bandung or to Jogja. I think the professional organization should organize how to use that bariatric instrument.
Thank you,
Thank you, Pak.
Prof. Riwanto.
Yeah.
Thank you, Prof. Riwanto. Any other question? Dr. Frans, do you have any question?
Thank you, Dr. Peter. I'd like to ask a question to Dr. Ernawati. In your experience, do you think that the number of cases that the OB-GYN perform for COVID-19 patient increase the likelihood of the transmission for COVID-19 to the operator, based on the protocol that you have described? Because I personally observed that the surgeon who perform these operations are not the one who were admitted to the hospital for COVID-19. I don't know, is it true or not? Because I think I saw that many of the surgeons who were who contracted COVID-19 were not the team that was doing the direct services to the COVID-19 patient. What about the surgeons in the OB-GYN for the team? Is it the same condition or is it different?
Yeah, thanks for the question, Dr. Frans. It's difficult to answer where is the infection came from. Is it from patient or another source? Yeah, that's right. That during the community transmission is also very high. So we difficult to recognize that this infection is came from patient or from the community. But if we show from our resident in training, from the report, and more than 50% they came from the community itself, I think. So from the patient is less than 50%. I think it's true from the other research that I have presented that wearing proper PPE can prevent transmission, and also it also depends on the situation, might be the physical condition of the surgeons, and then the status infection of the patient itself. Will influence the transmission process, but we cannot recognize that this is purely from patient or from community. I think it have impact too. But sometimes also it's difficult if they got infection from the family, but who bring this to the family, the surgeon itself or the other family, it's also difficult. I think the surgeon bring to the family, and then the family bring to the surgeon. It can be the situation is difficult.
Yeah, I understand that the tracing is very complicated, so we don't know where is the source of transmission. But for the time being, I think doing surgery for COVID-19, as long as we perform or as long as we wear proper PPE, is safe.
Yeah.
Do you agree with that?
Yeah, we agree with that. If we wear proper PPE, I think we'll prevent transmission. As I mentioned before, that we decided to C-section is to cut the time to contact with the patient, but for the preparation we also need time, so it's longer contact to the patient. So we decided if the patient in labor, we will do vaginally, but if no, we do C-section. This to prevent contact with the patient. I think if even though in vaginal delivery or in C-section we do proper PPA, I think the transmission will be lower, I think. But depend on the status of the patient itself, where is the position of the patient in very infected situation or in resolution, we don't know, Dr. Frans. Sometimes it also will have impact to the transmission.
Thank you very much. That is all, Dr. Peter, from
Yeah.
me.
Thank you, Dr. Ernawati and Dr. Frans. Any other question from the floor? I would like to invite Professor Andi to address the summary note. Professor Andi, the floor is yours. Please unmute your microphone, Professor Andi. Okay, I will skip Professor Andi, and I think one more question from the floor, if any. So I think we come to the end of this webinar. I would like to invite Mr. Max Downham to address the end note of this webinar. Mr. Max Downham, the floor is yours.
Well, thank you, Dr. Manopo, and I thank Professor Riwanto and Dr. Ernawati for their presentations. As a layperson, as you well know, and most of all others, I believe, I'm really not qualified to scientifically or technically judge the presentations, but I do compliment Professor Riwanto and Ernawati, Riwanto, I should say, excuse me, and Dr. Ernawati in terms of their presentations and the clarity and all matters that they displayed. I sat and listened to both presentations, and it seems like there are two challenges in surgery, as spoken from a layperson, which I'm sure may not be completely accurate or whatever, but the one is the amount of information that's available. Particularly in terms of Professor Riwanto, I've heard many presentations as a layperson again about robotic surgery, the pros and the cons, the advantages, disadvantages, and the same for laparoscopic procedures, endoscopic. And it just seems that as time passes, more information is available. And it seems that a challenge, I would guess, in surgery is to deal with all of the information, particularly the increasing amount of information, and to stay current and then make your choices. So I think information, the growing amount of information is in terms of being aware, and number two, trying to organize it and make judgments is certainly part of that. The other challenge, it seems, particularly from the presentation of Dr. Ernawati, is the unexpected. In this particular case, the COVID-19. It reminds me of a phrase, know what you don't know. And it seems, and I compliment both speakers again, the COVID-19 is a new, unknown, unexpected situation. And it seems, as the speakers indicated, they understood what they didn't know, and then they had to make the best of the situation based upon their limited knowledge. And that, of course, is a challenge as well. So, Dr. Manopo, those are my comments. Probably not very insightful, But at any rate, my takeaway, and I compliment Professor Riwanto and Dr. Ernawati and all of the other speakers, participants in the program. It's my honor for you to invite me to attend and to speak and to participate. So on behalf of the leadership of the International College of Surgeons and all of the global fellows, we compliment all of you in Indonesia for conducting these webinars. So thank you, sir.
Thank you very much, Mr. Max Downham, for your keynote address. And now we come to the end of this session. I would like, on behalf of the ICS Indonesia section, to express my gratitude to all participants for contributing in this event, and particularly for the speakers, Professor Riwanto and Dr. Ernawati, also to Mr. Max Downham from the ICS headquarters, to the Indonesia section office bearers, Professor Hendy Hendarto, Professor Andi, Dr. Frans Arifin, Professor Sri Maliawan, and also for our IT team, Mr. Bimo and Ms. Dewi. Again, thank you very much, and we will meet next month in different topic and different speakers. Thank you very much. Stay well and healthy. Goodbye.
Thank you, Dr. Manopo.
Thank you,
Thank
Dr.
you very
Prof.
much.
Riwanto, Dr.
Thank
Ernawati.
you all. Thanks,
Thank you.
Prof.
Thank you
Riwanto,
all.
Dr. Ernawati. Thank you very much.
Thank you, Dr. Peter.
Thanks.
Thank you all.
Thank you
Thank
all.
you.
Good night, Prof. Hendy.
Prof. Hendy.
Thank you.
Prof.
Dr.
Riwanto.
Dr.
Thank
Peter,
you.
Dr. Downham.
Thank you very much. See you later.